Hello, everybody. It's a pleasure to be with you. My name is Sahil Parikh from Columbia University in New York, and I'm really delighted to be here for this JSCAI Focus episode on the CLTI competency document. I'm joined by a terrific panel. Today we have Dr. Bo Hawkins from Oklahoma Health Sciences Center, and we also have with us on our panel Drs. June Lee, Clinical Assistant Professor from Case Western Reserve in Cleveland and University Hospitals Cleveland Medical Center, Dr. Amy Reed, Professor and Chief of Vascular and Endovascular Surgery at University of Minnesota, and Dr. Herb Aronow, Associate Professor of Medicine and Director of the Interventional Cardiology and Cardiac Catheterization Labs at the Rhode Island and Miriam Hospitals in Providence. We're going to start our program by just having a brief overview of the current document that's being published in JSCAI, and then we'll have a panel discussion to follow. And so without further ado, Dr. Hawkins, I'll hand the podium over to you.
All right, thanks so much, Sahil. Good evening, everybody. So I'll just spend 5 to 6 minutes or so talking about this project, how we started this, how the document development process worked, and then ultimately what the final product came to look like. And then hopefully that'll serve to stimulate some discussion. So the concept around this paper is defining competencies for endovascular specialists providing CLTI care. And I think, as we all know, for those of us that deal with patients with this condition on a regular basis, we understand that revascularization is performed by a variety of specialists. This is some older data, but newer data reflects similar trends, so to speak. And we know that for patients that have chronic limb-threatening ischemia, depending on where that patient is cared for and what type of institution, et cetera, that revascularization aspect of their care can be provided by either interventional radiologists, vascular surgeons, or interventional cardiologists. So there's quite an amount of variation, so to speak, in terms of who's performing revascularization, endovascular revascularization procedures in these patients. I think we also understand, and I think I've come to realize this as I've taken care of these patients as well, that CLTI seems to be a different disease animal, so to speak. These patients are exceptionally complex to take care of. They have a vast array of cardiovascular comorbidities, not to mention that their anatomy, when we talk about doing endovascular revascularization, is some of the most challenging that we encounter. So often what characterizes patients with CLTI is that they have multi-level below knee disease. The disease that they have is often calcific and lengthy, and these pose challenges when we talk about getting good outcomes with our endovascular procedures. And honestly, that is a direct correlate of how these patients are going to do long-term in terms of whether or not they go on to salvage their limbs. I think it's also fair to suggest that successful revascularization is a necessary component of the care of these patients, but sometimes that's insufficient to obtain best outcomes. So there's a lot of non-procedural work that goes into caring for these patients that might be just as important in various patient scenarios. And then lastly, I think it's fair to suggest that there's a lot of variation in the endovascular treatment patterns and the skill sets by revascularization specialists who do these procedures on these patients. And that can at times lead to suboptimal care and suboptimal outcomes. So beginning about 2 years ago now, kind of as the pandemic was beginning worldwide, SCAI launched an initiative to develop a multidisciplinary document that serves as a foundation for optimizing the training of endovascular specialists providing CLTI care. With that purpose, we wanted to understand what the ideal skill sets would look like for these endovascular specialists and what elements are necessary to be embedded within the various training programs across the country, such that individuals who want to take this on in their clinical practice are going to be very prepared and competent as they move into practice and take care of this patient population long term. And then the other facet of this was to understand, once we define competencies, how we might utilize that both in training programs and elsewhere to really heighten awareness around this condition, improve the quality of care that these endovascular specialists are providing, and then ultimately, hopefully that would translate to improved outcomes for individual patients. So we started this off in multi-society, multidisciplinary fashion, which I always think is the best way to go when talking about CLTI. We reached out to a total of 7 additional societies So there's 8 societies in total that participated in this project, including SCAI. And the society representatives included the Podiatric Medical Association, as well as 3 different vascular surgical societies, as well as 2 different radiology societies, and then also the Society of Vascular Medicine. So it was a very broad-based, multidisciplinary effort, and we approached each of these societies, found members who wanted to participate in the work group with us, and then work with us over the 18 to 24 months to develop this document and see it to fruition. The end product, just for the sake of time, I won't go through all of the entirety of the document, but I think it's fair to say that we were able to identify in total 34 competencies that we felt were important for endovascular specialists to have in caring for this population. We utilized the ACGME framework. Those of you in the educational space would realize what that is, but that consists of 6 core competencies. They include things such as patient care, medical knowledge, professionalism, problem-based learning and improvement, et cetera. And we developed those competencies to fit within each of those 6 subgroups. Here's a representative sample, one of the tables from the paper as it will soon be published. And you can see there's a lot of various competencies listed here. I think what you'll notice first off is that nothing really speaks to technical revascularization procedures. That's not to say that this document didn't heavily focus on that. In fact, it did. And we emphasize the importance for an endovascular specialist to be able to provide very advanced expert care in terms of aortoiliac, femoral popliteal, and even below knee revascularization. But I think also it's important to emphasize a couple of things. Number one, as we mentioned when I tipped this off, I think a lot of good care of the CLTI patient takes place outside of the operative suite or the angiographic suite. And so understanding these non-procedural skill sets, I believe, is very vital for endovascular specialists as well. I think the other thing that's important, within these competencies that I've listed here from this table, you see that we divided them into fundamental and advanced categories. I think we recognize that depending on the trainee or clinician experience level, not everybody's going to be an expert at everything, but this document provides a nice framework for individuals to understand what they should be doing and what they should be aspiring to doing if they really want to provide the best, most optimal care for these patients. So all in all, I think the take-home messages from this effort are as follows. Number one, I'm very proud of this multidisciplinary collaborative effort to define training standards for endovascular specialists. I think, I can't think of a lot of other endeavors, at least focused on CLTI populations, that had such vast, broad input from so many important stakeholders in this population. So that's, I think, a big win, and I'm really proud to be a part of it from that perspective. Number two, I think this provides us a robust blueprint to guide future educational endeavors. There's not been another task or document produced that speaks to this. We do have some existing guideline statements from various specialty societies. We also have some COCAT documents that speak to training standards, et cetera, but none of those really speaks definitively to the CLTI population. And I would argue that in this sense, this is an innovative kind of novel concept and novel product that we are able to produce. I would hope that in the future, this blueprint will serve to help existing training programs modify their curricula to meet perceived educational deficiencies. Programs that want to start new training programs or that want to start new training fellowships or endeavors can use this to guide the development of those curricula. I think that's also important that societies and maybe even industry initiatives can use this document to develop new educational products that might be helpful for clinicians engaged in CLTI care. And then I think ultimately down the road, this might even be a way to provide assessment for existing CLTI operators, but that'll take a lot of work to get to that point. So ultimately, why do we do things like this? I think what we're most interested in is improving the care of patients with CLTI. That's what we do. That's what gets me excited to come to work on a daily basis. And in this instance, I think we've chosen to first attack what an endovascular specialist should look like and make sure that when we start up front with these individuals, that we know that we're providing them the best educational products possible, the best training program environments, such that then when they get out into practice, they're able to utilize those skill sets that they've acquired. And then ultimately that translates into improved care. So with that being said, I think I'll stop right there, and then I'll hand it back over to Sahil for discussion. Sahil?
Bo, thank you very much for the quick overview. I know a process that took 2 years is hard to distill into a few minutes, but many of us on this call, I know Drs. Reed and Aronow and I participated in a similar multidisciplinary effort a few years ago, and that one took twice as long, I believe, to put together an appropriate use criteria document. So 2 years is actually not so long in the grand scheme of things. But yeah, I wanted to start, Bo, by asking you first, in terms of opening this up to all these different societies. It's to me, at least, the first time there's so many societies in the space that are represented. How difficult was it to achieve consensus amongst these broad stakeholder groups?
Yeah. So I think it was exceptionally difficult, but nonetheless gratifying by the end. Everybody comes to these. I feel like a lot of times people come to these discussions with a little bit of suspicion or kind of wondering what the underlying motives are for societies or a group of physicians or individuals to take on something like this. Honestly speaking, I remember thinking about this 10 years ago, and I was just struck by how varied the care was of this population. And I think we all recognize, irrespective of what the specialty of a given operator is, there is astounding variation in the quality of endovascular revascularization that is performed for patients with CLTI. And secondarily, I think I recognize, pretty early out of training that I knew that, I came to quickly understand that taking care of this population was going to need me to be a good doctor outside of the cath lab if I really wanted to help them avoid amputation and get optimal outcomes. So I think for me, this started as an initiative just wanting to kind of improve the care of that population. And so that was kind of the spark that initiated this all. So SCAI, I think, and Dr. Shishabor, who actually spearheaded a lot of this effort as well, was very fundamental upfront in saying we need to go to the other stakeholders in this space. We need to involve them because we learn just as much from them as they hopefully do from us. And this is something that they're absolutely invested in, and we can't get optimal patient care without their involvement. So we started with good motives. I was very pleased to see that everybody wanted to participate within that. I think that's a long-winded way of not answering your question, Sahil, but I would think, as we work together, we're able to build trust and then ultimately understand what we were seeking. It's mainly to improve care. That's kind of the common thread that really gets buy-in from all the stakeholders. And I think that's what allowed us to move forward. So that's how I'd answer that. I don't know if others.
No, I appreciate that. I think so. Dr. Reed, we've worked together on a variety of cross-societal things. And again, I am delighted that not just SVS, but VESS and SCVS were all three involved in this. As the lone surgeon on the call, I wanted to get your thought about the process and what do you think about the final product and how do you think that's going to allow us to have the rising tides raise all the boats?
Thank you, Sahil. And I think the unifying principle for all of us on this panel, but certainly all of us involved in the work, was that endovascular intervention is only part of the story. And I think one of the few times that I feel like we've come together and really said, we understand that caring for the CLTI patient is multidisciplinary. It's inherent in what we learn in vascular surgery training of the medical open endovascular options. And we started some of our own guidelines with the global guidelines in CLTI back in the JVS in 2019. And certainly as a surgeon representing the SVS, but speaking on behalf of Drs. Phil Goodney and Mark Schermerhorn for the VES and SCVS, we understand, as I hope all of the readership will, that we're just part of the story. We need podiatry. We need vascular surgeons. We need interventionalists. We need diabetologists, wound care. And I don't think that anybody doesn't want to be on the winning team of limb salvage. We all want to be on the A team to achieve the victory of limb salvage. And to get that victory, is multidisciplinary. It's a team approach. And so I think, we were pleased from our multiple surgical societies to be a part of what we all perceived and found in the end of the product was that it was a team approach and a unified approach for those taking care of these types of patients, that in the end, it takes the whole village to get it forward and have the limb saved. And none of us are going to be able to do it alone, surgeon or interventionist or medical physician. It takes the full effort of everyone. And I really felt like we captured that in the document.
Yeah, you heard it here first, folks. But I think that's the spirit in which the document seems to have come together, and the final product, I think, deserves applause. So congratulations, Bo and the team. So June, now thinking about the nitty gritty, as you guys participated in really writing the individual guidelines, Bo showed the sort of non-interventional components in his single table that he shared with us. For the rest, you'll have to read the paper on JSCAI or JVS. But what about the nitty gritty of technical skills and the paradigm of having core concepts and core skills and then advanced skills? What was your feeling about that? And what were some of the things that stood out to you that got both unanimous and maybe were controversial kinds of things that were difficult to agree on?
So I think one of the most interesting discussions that we've had, and it was quite heated, was how to really quantify or how to really gauge whether or not a person is ready to do advanced interventions in CLTI. There was a lot of documents out there, especially in coronary space. You can do X number of PCIs and be a qualified operator. But at the same time, we felt as a committee that not only is it the number of patients that you see or that you work on, but it's also the quality of care that you deliver. It's not just doing a tibial artery, it's about the complexity of the lesion that you're crossing, of how long the CTO is, whether or not you have to reconstruct the pedal arch. So we felt as a unit that purely putting a number on it isn't necessarily the way to gauge whether or not an operator should be an advanced CLTI operator. Hence, we actually did not place a specific number on what is determined to be competent. And it's really based on your training. And what we advocate for really is subspecialized training. If you want to be a true CLTI operator, you have to spend the time, you have to spend a year, 2 years, 3 years building that knowledge. And it's like Bo said, it's not just about competency within the procedure itself, it's about caring for these patients, working with your multidisciplinary team, working with your podiatrists and your surgeons to really do what's right for the patient.
So Herb, you've been a leader in our field, and as a clinician educator, but also as an investigator. How do you perceive these different suggestions for training be rolled out? What do you think will be the future of a document like this, and how will it be implemented?
Thanks, Sahil. First of all, I just want to thank everybody for the opportunity to participate tonight. And Bo, I want to congratulate you and your colleagues on just what was a heroic effort. I understand that 2 years may not seem like a whole lot of time, but I know the work was hard and the lifting was heavy, but important, right? I mean, SCAI certainly could have just said, hey, we're just going to go about this on our own and write a document. And that's the exact opposite of what happened. So I think the work product sets a precedent that we should try to maintain. So Sahil, your question's about rollout, right? I mean, what should this look like? And I guess, there's two ways to look at that. One is, rollout within existing training programs, and the other is rollout for people who are already out in practice. I mean, as we all know, there are things that happen after we're finished with training. And so I think we probably have to think about it in both ways. What I hope is, and Bo, you used this word a little while ago and also in the document, that this is a blueprint, right? So I think we're going to have to build on this with some granularity about exactly how we define when competency has been achieved within each of those domains, and then we're going to have to test, right? So I don't think that exists yet, right? The point of the document wasn't to get to that level of granularity, but I think we'll need to build on that for the purpose of training programs. And I hope we'll do it in a standardized way. I hope collectively across the professional societies that participated, that we can perhaps come to a consensus about that, so that we assess competency in similar ways at any institution where we have fellows who are in training. I think the same competencies would need to be put forth for those who are doing this on the job, if you will. It's just that there'll be others involved in ascertaining that, right? It won't be program directors. It might be cath lab or Angio Suite or OR directors. So, but I'd be really curious to know what others think about that.
Dr. Reed, the same question to you. I think that certainly from an endovascular standpoint, this document is much more granular probably than what's in the global guidelines about the techniques and the specifics of the technical details. On the other hand, I imagine that a surgical paradigm that's comparable to this either is in process or already exists. How do you think the surgical community will embrace these and incorporate these into their training programs and then subsequently in practice?
Well, a lot of this is already inherent in our training. We obviously for endovascular have requirements, and they're in various buckets of the number of endovascular interventions and lower extremity interventions. And so some of it is a matter of, like anything, when a new partner comes into the practice, what's their background in this? And so, certainly just like in carotid interventions, when if you do, over an 014 platform and rapid exchange, and your skills are such, and you enter into a new skill area that comes on over time, you're going to have mentoring and gain those abilities. And so I think similarly in training programs, I can see where, there's a grab bag of all the endovascular things that you do. And it's pretty hard to get very granular, as you know, probably from your board and from the ACGME. And so you'll have to have some buckets of that. And some of those, as technologies evolve, you will gain expertise and you will have colleagues that will be mentoring and helping with that. So I think, but certainly I think the more time you spend in that training paradigm. So as June was mentioning, the 1 year, 2 year, specifically in that endovascular arena, will afford you a lot of those opportunities to take care of those types of patients. So not it's just like, hey, I do a couple months of, peripheral and I'm ready to go. And I don't think any of us are anywhere in the document was really saying that. And so I think it's just dedicated time toward that and not a dabbling mentality of, well, I did a few of these, so let me do a few of these. It's really dedication to that. And so I think to the pathways, we've got this kind of set up, but I think to those that in cardiology and interventional radiology who are wanting to go that route, to really dig in and spend the time with that.
Yeah, no, I think we can say that there will be a forthcoming COCATS document for interventional cardiology that will be adapting many of these the specific elements into the training paradigms, which will be a leap forward for what we've got currently. And I think interventional radiology, I hear, is also doing the same. So that it helps that everybody is on a similar field and have similar language components to their training requirements. And I think also more importantly, for the vast majority of operators who are already out in practice to provide some sort of a benchmark or at least a reference point. What about in terms of the specifics of the evolution of these documents? Bo, writing the first draft and the first publication took long enough and was painful enough. How is this going to be revised and reviewed over time? Is there a prospective plan for that sort of periodic review, or are you guys not yet thinking about that?
Yeah, we've had some very preliminary discussions about that, but I think everyone recognizes that CLTI, it's in an interesting place right now. We're going to have a lot of landmark clinical trials published in the near future that might change revascularization strategies for a large proportion of patients. And then I think secondarily, the endovascular space in terms of device technologies, advances, et cetera, while moving at a rapid pace, I still feel like there's a lot to learn, particularly when we talk about below knee endovascular technologies. So it's a dynamic field. It's rapidly changing. This blueprint, as Herb alluded to, that we've laid out, I think is good and it can last for a while, but I can foresee the need to periodically update it, particularly as we roll this out and get more information. Periodic updates speaking to maybe specific types of endovascular techniques, maybe even adding in some volume metrics as we learn more about that and understand more about what trainees are currently being offered. I think periodic updates that speak to those elements are going to be important. So I could foresee once every 3 years, some kind of update coming in to supplement this kind of master blueprint, as we've called it.
Herb, you're very involved in the registries, specifically in the VQI and previously in the NCDR PVI. How do you think the registries can help with refinement of this document with respect to both outcomes and competency measurements? What do you think will be the future of that interface?
Yeah, I love that question, Zihal. I mean, I guess I'd start by saying I personally feel very strongly that anyone doing this type of work should be entering data into a registry. I think it's in the best interest of patients. It's the only way to really do quality at an institutional level, to be able to benchmark and to really look closely at where you're succeeding and where you could do a better job, right? So I think that in their current iteration, the existing registries capture volumes and often in-hospital outcomes. They are intended to capture longer-term outcomes, but I think all of us know that the follow-up is tough and there's a lot of missing data, and so it's a little harder to ascertain how people are doing over time. I think in a perfect world, we would figure out a way to make follow-up more complete, whether it's through patient-reported outcomes or using smart technology or whatever it is. We need to fix that piece. But I think there are also just a whole host of data elements that aren't in there, right? That might capture surrogate endpoints that reflect the training process, and again, not just the volumes, but certain skill sets, and whether, however we defined it, the trainee's been successful. I don't know that our registries necessarily do that yet. So I think there'll need to be a lot of work in that arena.
If I could just add a shameless
Sure.
plug for the VQI, that's really an outstanding way with the 1-year follow-ups. And, I would just say at our own University of Minnesota service line, we have interventional cardiology, vascular surgery, and interventional cardiology all doing those procedures, and then seeing what those limb salvage rates are at your 1 year. And so I think any registry that you can add that follow-up and ensure it's beyond the 30-day and it's out there far enough to see that is a great way to bring the results back. And also, I think including the patients, including those in some of our evaluations. What are the patient outcomes that they really want to see? We all, of course, limb salvage. But along the way, how often we do the procedures and their input on some of those, I think will be really great for an upcoming document and version 2.0 of this.
Yeah. So I know you're not thinking about it yet, Bo, but it sounds like there's already a movement afoot to refine it and to improve. And I think the idea of perhaps changing the elements of the database, Herb, to potentially enhance our assessment of competency amongst both practitioners as well as trainees is a terrific one. So June, to finish and to close, what was your favorite recommendation from the document? If you had one thing that you would like to highlight, what is that?
I think we've talked about this ad nauseum today. It's the multidisciplinary team, right? It's the team approach. It's the involvement of everyone. It's not just the endovascular interventionalist. It's not just the vascular surgeon. It's about getting good wound care, staying on top of the patients, making the patients take accountability for their own care. A lot of these patients, unfortunately, are still smoking. They're not doing what they should be doing in terms of wound care. They're either walking on their feet. You really have to be engaged with these patients. And it's frequent follow-ups. It's buy-in from the patients, from diabetic management, nutritionists, et cetera, to really make sure that the patient heals in an adequate time frame. So I think that's the most important aspect of our document, is the multidisciplinary management.
Well, with that, I think that's a terrific take-home message. We invite all of our viewers to take a look at the manuscript in any of the journals that it's published in. Certainly here, on behalf of JSCAI, I'm delighted to be here with my friends and colleagues on this call, and we look forward to hearing your feedback about the document and coming back to you next month with more endovascular therapy here at JSCAI. Thanks so much, everybody.